So as you can see here, we're going to start with some laparoscopic images, and we're going to refresh some anatomy of gynecology. As we look here, we can see from a laparoscopic image, looking from the umbilicus down towards the feet, the woman's anterior abdominal wall is up here, and her back is down here. You can see the uterus in the midline here, and you can see her ovaries and fallopian tubes. This slide is really for the benefit of appreciating that the fallopian tube is not directly attached to the ovary at its end. So the fact that an egg can get down into the fallopian tube for fertilization is pretty miraculous. But here you can see the end of the fallopian tube and the ovary. When a woman ovulates, the egg comes out of the ovary and goes into the fallopian tube. Here, hopefully into the fallopian tube. We can see here that the end of the fallopian tube and the fimbria are right here, and you can see some blue dye coming out of the fallopian tube, which was injected into her cervix. Remember that this is an open system, and that's why women can get an ascending infection, such as in PID. Here's a one-time image that you can see that as a photographer I find quite beautiful, and also as a gynecologist I find quite beautiful, because here you can see that we caught this at the exact time of ovulation. So an egg did just recently disrupt through the ovarian cortex, and here you can see the corpus luteum, or yellow body that's left behind once ovulation has occurred. Now, some of you didn't go into OBGYN specifically for the reason that you didn't like this image. But let's look at it for a second. Why do I put this up here? Because whenever you're dealing with a patient who has an ovarian cyst, you want to think, where is she in her cycle? Now, an adolescent may have irregular cycles, which is very common, but if we think about the follicular development and the ovulation process, the first part of the cycle is the follicular phase, then one comes to ovulation, and then the luteal phase. The luteal phase tends to be consistent for a 2-week period of time in most cases. And the follicular phase, the first 2 weeks of the development of the follicle, can vary in an adolescent. Why is this helpful? If you have a patient in your practice who has an ovarian cyst, you might want to think, where is she in her cycle from a developmental standpoint? Because these are functional cysts, which typically will go away. So the types of cysts: you can have a simple cyst, which means the echo texture on an ultrasound appears the same as water, or what the urinate looks like in a bladder. So there is no debris, no septations, and it's just clear fluid. A complex cyst may have septations, it may have debris inside, and a solid mass has no echo texture, as there's no liquid, and it's purely solid material. When we think about cysts that will typically go away, which are the most common, a functional cyst or a follicular cyst or corpus luteal cyst. So in the early part of the cycle, as the egg is developing, that's the follicular phase, and then the corpus luteum forms once ovulation has occurred. Sometimes there can be bleeding into a corpus luteum, and that's where you can get a hemorrhagic corpus luteal cyst. The non-functional cysts, meaning not related to ovulation and follicular development, are the mucinous cystadenomas and serous cystadenomas. Those are cysts that will persist and not go away. So let's look at an ultrasound image. Here you can see an ultrasound image of a simple cyst. Here is the follicular cyst that's forming. It has the same dark echo texture as the urine in the bladder, and that's why this is referred to as a simple cyst. So let's take a case. Here's a 16-year-old who presents with abdominal pain, nausea, vomiting, and a pelvic mass. Now, I hope by the end of this presentation, you will think pain, nausea, vomiting, and a mass equals concern for ovarian torsion. But let's look at this case. In this case, you can see the uterus, the ovary, and an ovarian cyst. Now, this case is not torsed. This is a hemorrhagic corpus luteum, and you can see the enlarged ovary. Now, in real life, they don't come with the U's and the O's highlighted on them, but you can see the uterus and the ovaries, and realize that the cyst is growing inside the ovarian cortex. So the normal ovarian tissue gets splayed out. So the normal ovary, if you think of it compared to a citrus fruit, a grapefruit, the normal eggs will remain in the skin of the grapefruit, and the mass, in this case blood from the hemorrhagic corpus luteum, will be the pulp of the grapefruit. Most of the time, a hemorrhagic corpus luteum will resolve spontaneously. In this case, she had surgery, but here you can see the normal eggs in the cortex, and this is the blood-filled cyst. So the normal ovarian tissue is this thin rim that is left behind, but we want to save that because that's her ovary. Here you can see a ruptured cyst and a pelvis full of blood. Typically, we do not operate on ruptured hemorrhagic cysts, but let the blood involute as long as the patient is stable. Why did we operate on this patient? Because she was hypotensive and had signs of hypovolemic shock. So we did operate on her to stop the bleeding, but typically this will resolve spontaneously. Now we have a 14-year-old who has abdominal pain and a persistent simple cyst. So typically, if a patient presents to your practice and she has a simple cyst, you'll want to repeat an imaging study to make sure that the cyst resolves. In this case, it persists. And here you can see the uterus, the normal ovary, and an enlarged ovary on this side, which has remained enlarged on ultrasound imaging over a period of time. Here you can see we're cutting into the ovarian cortex, and we enter into a cystic structure, and this is the cyst wall, and that can be removed, and the normal ovary remains. This would typically be a serous cystadenoma or a mucinous cystadenoma. They will not resolve spontaneously, and we need to remove them but save the normal ovary. This can be performed laparoscopically. How large a cyst can you have and still save the ovary? Well, that was a question we asked, and so we did a study looking at masses that were greater than 10 centimeters. And one of the things we need to figure out in these cases are these benign or malignant? And so we start to collect data. The data would be tumor markers, and we're going to go through that in a few moments. But here you can see a very large ovarian cyst. Why do I include these images? Because some people might say, this is really thinned out tissue. Is it really worth saving? Well, we know that this is the enlarged ovary, and it's quite large. Here's the cyst. Take out the cyst, save the ovarian tissue. And we did a follow-up study. So we looked at ovaries after the removal of the cyst and found, compared to the other ovary, that we had equal volumes. So we can save normal ovarian tissue and save the ovary. So even with large ovarian masses, as long as the tumor markers are negative and it appears to be simple in nature, so we're not concerned about a malignancy, then we would end up removing it and saving the normal ovary. How about if we have a 12-year-old who has abdominal pain and a solid mass? So on imaging, and once again, ultrasound is the gold standard that we're using here in gynecologic imaging. On ultrasound imaging, we see a solid mass, and it is persisting. Here you can see the ultrasound, the echo texture of the bladder, compared to this mass that now is all white with acoustic shadowing. Here is a larger one, and you can see a large mass involving this young woman's abdomen. Now, in these cases, we need to make sure if it's solid or solid and cystic and can be large, we need to do tumor markers to make sure that it's not a malignancy. In this case, you can see on an MRI that she has both liquid and solid material, so one would be highly concerned that this could be a malignancy. Now, the types of malignancies that adolescent women get and children get are typically germ cell tumors. So we want to go based on the benign or malignant question based on ultrasound and tumor markers. And here you can see the large mass that was removed. And the malignancy, when it comes to a germ cell tumor or a teratoma specifically, is based on the neurologic tissue, and this is brain here. These are the types of tumors that can have all cell lines present. How do we figure it out? We typically check tumor markers. Remember that the tumor markers that we're looking at in the children and adolescent population are different than adult gynecologic malignancies. So we're looking more at germ cell tumors, which will tend to be checking AFP, HCG, LDH, inhibin are the typical ones. We do also check CA125 due to epithelial tumors, which may be borderline malignancies. So you want to check the tumor markers and have your ultrasound imaging to help you know if it is simple, cystic, solid, or complex with both types of products present. In addition, we can ask the question about platelets. And platelets have been noted to be elevated in ovarian malignancies, both in adults and in adolescents. So that may be another helpful marker. A 16-year-old who presents with an abdominal mass identified on a routine yearly visit with her primary care, and you want to evaluate, it's a 10-centimeter solid and cystic mass. Tumor markers are negative. And then the question is, how does this patient get managed? Well, this really relies on where the patient is referred. And the management can vary, and the varied types of management are all justified by the appropriate professional societies. So a patient may go to an adult gynecologist who may be offered an ovarian cystectomy laparoscopically. If she goes to an adolescent gynecologist, she'll be offered a laparotomy. Why the difference? Because of the concern that there can be abnormal cells or malignant cells present even with negative tumor markers, more common in children and adolescents, and so we worry about the spillage of the mass and the contents, which would upstage the young woman and possibly require chemotherapy. The pediatric oncology group recommends removal of the mass if it cannot be done in a fashion where there is no spillage, then an oophorectomy is recommended. So these are all supported by their professional societies, but it raises the question of what should we be doing, and that is a challenge. But as a pediatric and adolescent gynecologist, we do recommend that these be done as an open procedure with removal of the cyst with preservation of the ovary. So it is a surgical conundrum. There are different approaches to the same clinical case. Now let's look at a 10-year-old who has abdominal pain, nausea, vomiting, and a mass. Well, I shared with you earlier on that I hope your response is going to be, I have a concern for torsion. So nausea, vomiting, and a mass, one needs to at least consider the possibility of ovarian torsion. And here you can see a torsed ovary and a torsed fallopian tube. And then the question comes up, is this dead or alive? My response is, ovaries are always alive unless they are gelatinous and falling apart. If there is any type of structure remaining, I would very much try to save all ovaries because of the importance of ovarian structures. Here you can see a fallopian tube with torsion. So a normal uterus, ovary, and a fallopian tube that has twisted 3 times with a cyst involving the fallopian tube. This is still viable. It's still pink. So we want to detorse this or untwist it and then take out this cyst so it won't twist again. You can see another tubal torsion, and tubal torsions can be a challenge, even more so than ovarian torsion. So what are the diagnostic criteria for torsion? It's a challenge. Why do things torse? Based on the weight and the size, changes the torque. So with a mass or a cyst present, it may increase the risk of torsion. But girls can torse normal ovaries without a cyst present. We don't understand that, but girls can torse normal ovaries. So what are the signs and symptoms? Typically waves of pain with nausea, plus or minus vomiting. If we wait for low-grade fevers or an elevated white count, we may be waiting too long because that usually is when tissue necrosis has occurred. So we try to intervene before we lose normal tissue. She may have tubal peritoneal signs from the torsion. She may have peritoneal signs such as nausea and vomiting and rebound or guarding. But there can be a varied spectrum on the presentation of symptoms with torsion. So with ovarian or tubal torsion, we want to act as soon as possible. It is a surgical emergency. Whether it's approached laparoscopically or by laparotomy, it's whatever the surgeon is comfortable performing. The surgical managements really revolve around the point of viability. Most ovaries and tubes can be saved. They can be detorsed and saved. The risk of malignancy is extremely small based on studies that have been done, but if there is a mass present, one would want to remove the mass if possible. Sometimes people will detorse the adnexa, drain a cyst that's present, and then come back later to take out the cyst wall if it's difficult to remove based on the edema from the torsion. So the surgical procedure would involve detorsion or untwisting, cystectomy if it can be performed, a salpingo-oophorectomy or removal of the tube and ovary if they are dead, but remember, that is rare. You may need to wait a while for the normal color and vascular appearance to return, and if there is a problem where it doesn't appear to be vascularizing the way you would anticipate, you may consider a bivalve procedure, which I'm going to present now. With diagnosis, one would hope that we could rely on ultrasound, but we find that ultrasound can be a challenge. We know from ultrasound studies that Doppler flow is not helpful. So one can have Doppler flow with torsion, or one can have absence of Doppler flow even in a normal ovary. So in this study of 41 patients with torsion, we found that the most reliable finding was asymmetry of the two ovaries. The challenge being, if you have a cyst present as the cause of torsion, you are going to have asymmetry by definition. But then you would look for edema or peripheralization of follicles. But really, it's the difference of ovarian size that is key, mainly based on the edema. The bivalve technique that I mentioned is shown here. You look at that ovary and it looks fairly dark. The question is it dark because it does not have arterial blood flow? Or is it dark because the ovary has a capsule and it has arterial blood flow, but since there's a capsule and compromise of venous return, the arterial blood cannot enter. So what does that mean? If we cut into the ovarian cortex, can we save the ovary? And here you see that. We cut into the cortex of this ovary, and you can see that the color returns. This is over about a 45-minute period of time. You can see the fallopian tube now looks normal, as it didn't before, and the ovary, which looked fairly dark and dusky, is normal. That was published in Fertility and Sterility in 2002. Now, what about pexing an ovary? If a woman torses an ovary due to an ovarian cyst, we know the etiology, and we will typically take out the cyst and not pex the ovary. What does that mean to pex an ovary? It means to sew it in place, to try to decrease the chance that it's going to twist again. But if you have a child who torses a normal ovary, you may want to consider having the surgeon sew it in place to decrease the chance that it will twist again. In addition, we offer oophoropexy to children or young women or adult women who have a history of prior torsion where they lost one ovary already. So if they only have one ovary remaining, she may want to have that ovary sewn in place because there are a number of case reports where there is bilateral asynchronous ovarian torsion, and it would be tragic if both ovaries were lost and she was left agonadal. So the key points of torsion are pain, nausea, vomiting, and a mass is torsion until proven otherwise. Ultrasound is helpful, but Doppler flow is not. You're mainly looking for a size discrepancy, peripheralization of follicles, and edema. Most torsed ovaries can be saved. We want to drain a cyst or remove it if it is present, and we tend to pex normal ovaries. We consider oophoropexy in girls with a single ovary. And in addition, when any girl or young woman who has had torsion reaches adolescence, we may consider the use of an oral contraceptive pill to suppress follicular cyst formation, because a follicular cyst can lead to torsion also, based on the physics and the change of the weight of the ovary. So use of ovarian suppression is helpful with a hormonal pill. Now let's shift gears a little bit. Let's say we have a 15-year-old who has pelvic pain. It's pain for 6 months. It's worse with her period. She misses school. She calls your office with increased pain. She goes to the emergency room and she's found to have a 6-centimeter ovarian cyst. And you ask that she follow up with gynecology. What's going on here? She's had chronic pain, and now she has increased pain, and she has a 6-centimeter cyst. Well, you're really going to want to know, does the cyst go away? Is this a functional cyst or not? Are we dealing with one problem or two? Well, she gets seen again. She started on an oral contraceptive pill for treatment of her dysmenorrhea and ovarian cyst prevention. So the current cyst that's present will not go away based on the use of a combination hormonal pill. But a combination hormonal pill will hopefully suppress future ovulation, so that when you bring her back for a repeat ultrasound, she won't be ovulating again with a new cyst, and you assume it's the same cyst that has persisted. So the use of a hormonal pill will keep a new cyst from forming, but will not make the current cyst go away. She returns for an ultrasound 4 weeks later, and it's normal, so the cyst resolved, but she is still having pain. So what do we do? Dysmenorrhea is fairly common. It interferes with young women's lives. Dysmenorrhea is typically treated with the utilization of combination hormonal oral contraceptive pills or progestin-only pills to try to treat the symptoms of pain with menses, in addition to the utilization of non-steroidal anti-inflammatory agents. But what happens when that hormonal therapy and the non-steroidal anti-inflammatory agents don't resolve the problem? We typically do a trial of NSAIDs and oral contraceptive therapy for 2 to 3 months. And if the pain persists, then we need to move on because we don't have a diagnosis. So when is it no longer dysmenorrhea and further evaluation is required? Well, we're talking about endometriosis. Endometriosis is the presence of endometrium, meaning glands and stroma, outside of the normal location, which is inside the uterus. So these cells can end up in other locations throughout the body, but typically, and most typical, in the pelvis and in the posterior cul-de-sac or the anterior cul-de-sac. This endometrial tissue responds to both estrogen, progestins, and also androgens, and there is no way to diagnose endometriosis by a blood test or a radiology imaging study. So the way to diagnose endometriosis in an adolescent is to perform a laparoscopic procedure and visualize the disease. It is important that the gynecologist or surgeon who is performing the surgery be familiar with the appearance of endometriosis in young women. It does look different than most of us were trained to see in adult women. We don't want to normalize the symptoms. So a young woman has pain, and she says, "It's pain. I can sort of live with it." That's not the approach we want to take, because that's normalizing symptoms. Or a mom who said, "I had severe pain, your grandmother had severe pain, we all lived through it." The challenge is that if endometriosis is present and is not diagnosed, it can lead to pain and more severe pain, but it can also lead to difficulty conceiving and infertility. The etiology of endometriosis is unknown. There are a number of different theories as to the etiology, but no one etiology explains all cases. The most prevalent theory is retrograde menses, but we know that there are cases of endometriosis that occur even before the onset of menstruation, with the onset of breast development. Does that make sense? Well, with breast development, we have estrogen circulating through the system, and so if there are cells present based on the Psalomic metaplasia or transformation theory, then those cells could be activated by the circulating estrogen, and stimulate endometriosis. Hematologic or lymphatic spread, well, that can explain the rare but reported cases of endometriosis in the lung or in the brain. Retrograde menses would not explain those cases. Most likely there is a combination of these theories, and they could also include immune deficiencies or environmental exposures and or genetic predisposition. Endometriosis is an unusual disease in that the symptoms can vary. Some women have no symptoms at all and only find out because they're infertile. 20% of women who have unknown cause of their infertility have endometriosis. Endometriosis can also present with pain, pain with periods, pain in between periods, pain with sexual activity. They can also have gastrointestinal symptoms such as constipation and diarrhea. And I think there's a great overlap between the patients who see gastroenterology or gynecology. There can also be urinary symptoms such as pain with urination or urinary frequency. Pelvic masses or endometriomas are rare younger than age 22. They do occur, but they're not common. There are many co-occurrences: interstitial cystitis, IBS, kidney stones, TMJ, migraines, fibromyalgia, and vulvodynia have all been reported in women with endometriosis. The cost of endometriosis is huge. It affects women's performance in life, their medical costs, and their ability to function in society. Our vision is that if we can find endometriosis in young women, we can improve their long-term life outcomes. Endometriosis can affect a young woman's dreams. It can affect her ability to perform in school and academic environment, socially, and through sports. It can also create concerns about her future fertility. So let's look at a 15-year-old with pain. What do we do? Would your response be different if her mother had a history of extensive endometriosis? Do you ask your patients' mothers if they had a history of endometriosis, or a paternal aunt or a grandmother? I think we should be doing that, because if we could find endometriosis in young women, we can improve their future. What if the young woman who's your patient is the product of in vitro fertilization due to infertility? Should we intervene sooner? What if that mom had no pain at all, but only found out she had endometriosis because she was infertile? Those are questions that are at the cutting edge of the questions that we ask as we take care of adolescents with endometriosis. Now, if you're going to refer your patient with endometriosis or potential endometriosis to a gynecologist for evaluation, is she going to go? Lots of young women are afraid that if they go to a gynecologist, it equals a gynecologic exam or a bimanual exam. That is not the case. As a gynecologist, we need to rule out an obstructive anomaly. That might be accomplished with the utilization of a Q-tip to document that there's a patent vaginal tract, or ultrasound imaging. But we do not routinely do gynecologic exams in young women who have pelvic pain that's consistent with dysmenorrhea and endometriosis. If we are going to do an exam, we might do a rectal abdominal exam. But if you're doing a pelvic exam looking for uterus sacral nodularity or an endometrioma, as many of us were taught in medical school, we're not going to find that in an adolescent population because those findings are typical of adult women. The diagnosis is a challenge. We have no blood test. You cannot see endometriosis on an ultrasound, CAT scan, or MRI. And so the diagnosis is by laparoscopy, where we make a diagnosis and perform surgical management by destroying and removing the disease that we can see. But there is no surgical cure for endometriosis either. How often does this occur? If we look back at studies, we can see the bottom three studies here relate to adolescents. So the study by John Rock in 1996 asked the question, if you're an adolescent woman who is on an oral contraceptive pill and non-steroidal for treatment of dysmenorrhea, and you have a laparoscopy, what's the chance that you have endometriosis? And their number was 67% in Atlanta. We did the same study in Boston and found 69%. So it's not just geographic information or the surgeon's specific information. But how are we making that diagnosis? So 67 to 69% of women who have pain after 3 months of an oral contraceptive pill and nonsteroidal anti-inflammatory agent who go on to a laparoscopy have a close to 70% chance of having endometriosis. But those studies were done in the early 90s. When we do laparoscopy, we operate off of TV screens. The digital imaging has markedly improved. So when we look at those numbers more recently, the number is probably more like 96 to 97%. How about the symptoms? If we take that patient population from our study and ask what symptoms did they have, this is one of the first studies that actually said adolescents don't have the typical pain that adult women were always found to have with endometriosis. Typically, endometriosis pain was reported as cyclic pain, but in this study, only 9.4% of adolescents reported cyclic pain. They had acyclic and cyclic pain. That makes it more difficult for a primary care provider because this young woman may have pain all the time. But the key is she may have daily pain or unpredictable pain, but typically it gets worse with her period. In this interesting study, the Endometriosis Association asked 4,000 women with known endometriosis how long did it take to get a diagnosis, and most saw 9 healthcare providers until they had a diagnosis. Also key in this study was that 50% had symptoms before they were 24 years of age. That means we're not doing such a good job at picking up this endometriosis in adolescence. The delay has been found in many studies, and in the US, 11.8-year delay in this study, and in the UK, 6.7 years. No wonder women with endometriosis are frustrated. How about adolescent endometriosis? Well, this paper was published in 2013, and their conclusion was endometriosis in adolescents is a hidden, progressive, and severe disease that deserves attention, not just compassion. That was the title of the article. What they did was review all studies on adolescents, and I'm sad to say there are not that many of them, and these are the studies of adolescents. So what is the current algorithm? If a woman has pelvic pain, whether it be cyclic or cyclic and non-cyclic, a trial of NSAIDs and oral contraceptive pill therapy for 3 months, and if there is still pain, proceed with a laparoscopy. What is laparoscopy? Well, it's a day surgery procedure. It's minimally invasive. It is both diagnostic and therapeutic. Typically takes less than an hour. A 5-millimeter incision is made in the umbilicus and in the suprapubic region. We look inside, see if there's endometriosis, destroy what is there. The patient goes home the same day. She's out of school the day of the procedure, and typically 2 days afterwards. There is no correlation between the amount of disease and the amount of pain. So you can have microscopic disease and excruciating pain, or you can have a pelvis full of endometriosis and only find out because you're infertile. The staging criteria was set up by the American Society for Reproductive Medicine. This was set up from a fertility standpoint, not a pain standpoint. So the stage of disease starts with the least amount, and you can see the lines and the black areas represent endometriosis, and the more advanced, or stage 4, leads to infertility based on the lesions and also adhesions where the egg can no longer get into the fallopian tube. And here you can see the lesions and the adhesions. Typically, adolescents have stage 1 or stage 2 disease. But there is no correlation between the amount of pain. And in this study, patients with stage 1 disease were more associated with pain. Why is that? Well, you can see the different color lesions. And why are there different color lesions? Most likely they're making different chemicals and result in differing amounts of pain. This study from 1998 showed that the most painful lesions were the clear lesions and the red lesions. The ones that I was trained to appreciate when I was a medical student, the black lesions or the purple lesions, are the least painful. It's the old hemosiderin that's present. It's been there longer, but it's burnt out or it's less painful. But the more painful lesions tend to be the clear and the red lesions, and those are the lesions that we find in adolescence. these cells are making inflammatory markers. So what you can see is this is an inflammatory response where endometriosis is making all types of cytokines and inflammatory markers that can cause pain. So it's not just the presence of the lesions, it's what the lesions are producing that lead to adhesions and pain. Here you can see the different types of lesions we typically see. There can be clear lesions and red lesions. Here are the red lesions. Here are some of the clear lesions, lighter brown lesions, and the dark ones. These are not the most common that we see in adolescence. These are, but if you're not trained to see these, you might miss it. Here you can see more clear lesions. This is an underwater technique to see the lesions. This is under a liquid distension media. It looks like endometrium floating. Here's more extensive disease. This young woman had a laparoscopy and was told she's normal and that she should see a psychiatrist. The sad part is she has lesions, but her gynecologist wasn't familiar with what they look like. So from this distance, looking at the pelvis, it looks normal. But if you get close, and even closer, you can begin to see these clear lesions. So that gynecologist missed the diagnosis. Here you can see the uterus and ovaries, and here are lesions here that we can then destroy and burn the area in order to destroy the lesions. Here you can see it under a liquid distension media. The camera is actually put underwater, and here you can see the lesions floating. They move. It looks like algae. See the little blood vessels in them? That's why we're studying angiogenic factors relating to these types of lesions. But here under a liquid, it's easier to see, and you can see those lesions moving. That is endometriosis. So what is the surgical approach? The surgical approach is that fertility needs to be preserved. We can resect or destroy the disease by lots of differing techniques. But the most important thing is that endometriosis can be frustrating for patients, her family, and for healthcare providers. That does not mean we should jump to radical surgery that's typically done in older women once they have completed childbearing. Unfortunately, a few times a year, I see adolescents from around this country who are told they need a hysterectomy because everybody is frustrated. That is not the answer, and it is not a cure. Whether we excise or destroy, studies have shown that both work equally well for stage 1 or stage 2 disease, but make sure that the gynecologist who's doing the surgery is familiar with the types of lesions. So here I'll share with you the technique that we use. Here are clear lesions, and we destroy them with electricity. So here you can see the electrical current will flow through that L hook. Here you can see a lesion that I'm about to lift up. It's a thread-like lesion. That's the start of adhesions, where two areas of peritoneum are stuck together. And there you can see the disease. It's being destroyed. And now using electricity on a low wattage, we can destroy the disease that's present there to debulk or destroy the disease we can see. Once again, we can't cure this surgically, but we can destroy the disease that's present and then use medicines afterwards to keep it from growing. Here's another lesion, a plaque on the side of the pelvis here that may be difficult to see, but we can lift it up. And you can appreciate how difficult it sometimes is to see these types of lesions. How about surgical outcome? Well, we do have surgical outcome in adults, and now we have the first study of follow-up in adolescents. So the surgical outcome in adults show that if you do a surgical procedure and destroy the disease or remove the disease, the recurrence rates are fairly high, and that shows that we need to be using medicines after surgery. There is no surgical cure, so we use treatment afterwards until childbearing is complete or fertility is no longer desired. We try to limit lifetime surgical procedures, and hysterectomy should not be offered to adolescents. So what types of treatments do we use? We try to suppress menses. Why do we suppress menses? Well, if we can suppress menses, we're suppressing the endometrium, the inside lining of the uterus. If we suppress the endometrium, we're also suppressing endometriosis because those are the same types of cells that are present elsewhere in the body. This technique has been around a long time. It was originally called the pseudo-pregnancy technique because we're fooling the body into thinking it's pregnant with a constant level of estrogen and progestin, similar to pregnancy. What ends up happening is the lining of the uterus, the endometrium, becomes thinned out. It gets very thin and decidualized from the progestin. So we typically use an estrogen and progesterone pill in a continuous fashion, usually a progestin-dominant pill. Or we could also use progestins, Depo-Provera, Agestin. Danazol was classically used, but we don't use it much anymore, mainly because it's a synthetic testosterone-based drug, and the side effect profile is not acceptable to most adolescents because it can cause deepening of the voice and hair growth. GnRH agonists we do use when other treatments are not effective because we try to start with the medications that have the least side effects. So let's look at some of them. So combination hormonal therapy is really inhibiting ovulation, decidualization of the endometrium, we're decreasing menstrual flow, and we're trying to use a monophasic progesterone-dominant pill. Now I spend a lot of time trying to explain to women how to take the pill this way. We want them to take the 3 weeks of the hormonal pills, and then when they get to the first placebo pill, they do not take placebos, and they start a new package immediately, starting here, back at the beginning. So they use more than one pack of pills per month. We as healthcare providers need to write the prescription the right way so that they're taking the pill. 4 packs will last for 3 months, and we write on every prescription 1 pill daily without breaks or placebos for treatment of endometriosis. The goal is suppression of menses. We try to take the pill or have the young woman take the pill at exactly the same time every day. Even if she's exact about it, she may get breakthrough bleeding or irregular periods. There is no correct answer as to how to manage that breakthrough bleeding. You could continue through, improve the timing. If there is an antibiotic or other medication that's interfering with absorption or with metabolism in the liver, then we might want to change. And changing to a different therapy is possible, but it really is trial and error. Progestin-only therapy may or may not inhibit ovulation. It does decidualize the endometrium. The goal is to decrease menstrual flow, and we try to use progestin-only pills or the mini pills, Agestin or norethindrone acetate in a 5 to 15 milligram dosage, which is the FDA-approved dosing for this therapy, or Depo-Provera. We have performed a study of adolescents with the utilization of norethindrone acetate for treatment of endometriosis. And we found great success with this therapy, and it is one that we have increased utilization with minimal side effects or decreased side effects. GnRH agonists can be utilized. We specifically use them with add-back therapy. So just to remind you, with a GnRH agonist, we are lowering estrogen and progesterone. It's creating a prepubertal state. As many of you may know, these are the same medications that are used to treat precocious puberty. With lowered levels of estrogen and progesterone, we do end up creating side effects that are similar to menopause. So without add-back therapy, which is adding back a small amount of sex steroid, patients will have mood swings, vaginal dryness, and potential bone loss. So I always prescribe GnRH agonist with add-back therapy. The add-back therapy was a hypothesis put forward by Dr. Robert Barbieri in 1992 with the idea that at very low levels of estradiol, we have bone loss. At high levels of estradiol, we have stimulation of endometriosis. If we could get to a therapeutic window where we do not have bone loss and we have minimal effect on endometriosis, then a woman could live happily in this zone for many years. The current FDA-approved timing for the utilization of an agonist can be confusing. So why do I say years? The FDA-approved dosing with add-back is for a year, but I have had patients on GnRH agonist with add-back for 14 years or longer. We do follow bone density tests, but if a patient is not functional on other therapy, and in order to avoid frequent operations, this may be the only option. I don't use it as a first-line therapy, but it is an excellent choice for people who are not doing well or functioning in life on other treatment options. Is it safe for adolescents? Well, this was a pilot study we did at Boston Children's Hospital looking at bone density in adolescents with the utilization of GnRH agonists with add-back therapy. And we have a longer prospective randomized trial ongoing currently. What are outcomes for adolescents with endometriosis? Well, this is the first long-term follow-up study of adolescents. And we looked at 90 patients aged 12 to 24 who had a laparoscopy which showed endometriosis, and it was surgically destroyed. Then they were treated with medical therapy. And if they had a recurrence of pain and had a second laparoscopic procedure, we asked the question, did the endometriosis get worse? Why is that important? Because we want to know if the disease is progressing. It also answers the question, are we causing adhesions from our surgical procedure? Many people are afraid to have a laparoscopic procedure because they think it's going to result in adhesion formation. And I think that is old data from when we were doing these procedures as open laparotomies. This study showed that there was not an increase of adhesion formation, and by doing surgery followed by medical therapy, it was a trend to retard the disease, so it was not progressing. Another study asked the question, do we really need treatment after surgery? So this study looked at 20 women who had a laparoscopy with destruction or excision of endometriosis, and then the use of medical therapy afterwards was the patient's choice. But interestingly, 6 of the 17 patients used hormonal therapy, but 8 out of the 17 had recurrent pain. They underwent another laparoscopic procedure, and they didn't visualize endometriosis. The challenge here is I don't think we can say that the pain wasn't due to endometriosis just because we couldn't see it, or on the biopsies that were selected, they didn't see it microscopically. So in this case, 50% of these patients had pain or recurrence of pain, which is similar to the adult data, and that's why we recommend medical treatment after all cases of surgery, since there is no surgical cure. So in this case, 50% had pain, 50% had a second operation within 2 years, and so we want to use a diagnostic procedure for surgery and diagnosis, and then use of medical therapy afterwards to keep disease from progressing. So just to be clear, if a woman has pain with her periods or in between her periods, she starts with hormonal therapy and nonsteroidal anti-inflammatory agents, and if she has a persistence of pain after 2 to 3 months, then she proceeds with a laparoscopic procedure. The laparoscopy is done to diagnose and to surgically destroy all visible lesions. It needs to be done by someone who can appreciate the disease in the adolescent population. And then, since there is no cure for the disease, postoperative medical therapy is recommended until childbearing is complete. We are doing research on this topic, and I'm pleased to say we established the Boston Center for Endometriosis 2 years ago with a $3 million gift to Boston Children's Hospital from the J. Willard and Alice S. Marriott Foundation. We're setting up a biorepository and a clinical database to try to find new treatments and a cure for adolescents and adult women with endometriosis. And it is a center where we are following patients with endometriosis from teens through adulthood. Our goal is to develop a non-surgical diagnostic and also new treatments and a cure. In addition, I'm pleased that we have had increased work internationally, and the Boston Center for Endometriosis has worked with other centers around the world, including the Oxford team, and there is a series of papers that will come out in November of 2014, which show a harmonization project for improving world research on endometriosis so that surgical material is collected the same way and questionnaires are performed so that we can share data and improve endometriosis research internationally. Awareness is important, and I direct you to differing websites. YoungWomen'sHealth.org is a website that Jean Emmons and I started at Boston Children's, the Boston Center for Endometriosis, and the Endometriosis Association. There is educational information for professionals in the Journal of Pediatric and Adolescent Gynecology. In addition, the youngwomens.org website, youngwomenshealth.org, is a website that's available to you with handouts on about 300 different topics in English and in Spanish. It's free, and one can use this to gain information for patients and families regarding all types of medical issues and mental health issues relating to teen women. Education is important. The website I mentioned, we do have a conference each year for teens and their families with endometriosis. We've created educational material, and we have blogs and newsletters for teens with endometriosis.